Many thanks to the two speakers. There's also other panelists who should join us from now on. So we will ask them to come. Thank you. So I guess the question that the panelists would like to address to follow up on the two speakers' presentation is like, how can we make sure that in the Indian context, we're going to deliver the right quantity of care to the right person in the right way? And I guess we have some ideas following Richard's presentation. And I'm first going to ask to the new panelists to introduce themselves. And once it's done, I've got a good question, I guess. So Haba, would you like to start?
Good afternoon, everybody. My name is Abha Mehendirata. I'm a pediatrician and a public health specialist by training. I work for the Global Health and Development Group at Imperial College London. I also work for the Institute of Healthcare Improvement, IHI, which is based in Cambridge.
Thank you.
Good afternoon, everybody. I'm Vikram Gota. I'm a clinical pharmacologist at Tata Memorial Center, Mumbai.
Good afternoon. I'm Mathieu Inchoumi. I'm the country head of Roche Pharmaceutical in India.
Okay, thank you. Then I think that's the first question that you may want to answer or to introduce is what is actually done in India to ensure that we deliver the right quantity to the right person in the right way? And in the view of what has been presented, what would you suggest to improve, or what are the ways to change and to go forward?
So as I mentioned, as I introduced myself, I actually work for two very different organizations. And they both work in efficiency, but actually in two different aspects of the healthcare system. So with Imperial College London, what the work we are doing is more in terms of allocative efficiency, and I could resonate with the slides that you produced in terms of what is the guidance that is being provided to clinicians? What is the data that needs to be collected to be able to monitor at the policy level and for the clinicians to monitor at a local level on what's the quality of care that's being developed? So coming to the Indian context and what we have been doing and supporting and working with the Government of India, in 2014, when the government was planning to launch the National Health Assurance Mission, which did not get launched it was scheduled to happen in 2015, but in 2014, in preparation for that, the government established 4 task force saying that we need to reflect and see what needs to be done better in terms of healthcare delivery, and before we launch this very ambitious scheme. One of the task force for which I am a member was on standard treatment guidelines. So the main mandate given to the task force was that can we have more rational care for the secondary care schemes, which is the RSPY scheme. But when the task force members met, they said it would be wrong for us to make guidance only for secondary care, because already we have a skewed health system which is more procedure driven, and if we make guidance only for that, what about who gets referred from primary to secondary care? How better do we manage primary care? And then with a lot of consultation, we decided that we needed guidance which moved through the continuum of care from primary to secondary care. The second question came in is, do we have time to make guidelines? When we look at organizations like NICE, which make guidance for the UK, it takes about 18 months to come up with one guideline. We were in a hurry. And also there were a lot of guidelines already available for most of the key topics. A lot of guidelines produced in India by the various professional bodies, a lot of international guidelines. How do we pick the best one for India? How would we know that it's most suited? How would the practitioner who's going to use the guideline trust it? And with a lot of stormy debate and discussion, we found that it was hard for us to parachute an international guideline because there were a lot of contextual issues, implementation issues. It was just not possible. Some of the recommendations were not possible to do it in India. And though there were a lot of domestic guidelines available, we also found that there wasn't a lot of documentation on what is the process followed in making the guideline. There wasn't a lot of information on what evidence it's based, if recommendations have been adapted to the Indian context, was conflict of interest managed, there was very little information, and we couldn't comment on the process. So we decided that we need to have a methodology which can inform making guidelines in the country. It needs to pick up on from the best guidelines which we can quality check the source guidance, and where required, when we are adapting to the Indian context, we have a transparent mechanism of mentioning why we are moving away from the best practice evidence and why it's not possible to do in India in terms of cost, in terms of implementation challenges. So the ministry constituted under the task force 10 clinical subgroups to make guidelines on 14 prioritized topics, which are expected to be released sometime this year. But while making the guideline, some of the recurring questions which came up, which I saw your slide on cost effectiveness, it was sometimes very hard for us because we did not have a mechanism to look into cost effectiveness while formulating recommendations on, is this the best value for money? Having said that, in parallel, we are working again with the Government of India and the Department of Health Research to create or institutionalize a mechanism by which, going forward, cost effectiveness can be taken into account when the government is thinking about healthcare spending. And we hope that the two programs at some point will converge. The HTA program, which is going to be established under what will be the Medical Technology Assessment Board, the recommendations of that can feed into the guidance, because we do want whatever is the most cost-effective intervention to be the recommendation in the guideline program to be there. I'll just take 2 minutes, if I may, to add a few things. While making the guideline, it was also important that we had implementation tools. It's fine to have a very big guideline. How do we put it to practice? That itself is such a different thing. And one of the components that are there is what the guideline developers have developed, quality standards, which are the prioritized most important recommendations that they have felt will have the maximum impact on outcomes. And these quantified recommendations, which are quality standards, can be used in two ways. They can be used at the policy level to monitor the quality of care that is being delivered through the public system or purchased by the public when delivered by the private system. More important than that, I think these quality standards need to be used at the local level. We have so much of data at the local level generated, but there isn't sufficient capability built in the frontline clinicians and teams to look at the data and find out what's the reason why they're not doing so well when they look at the data, why they're not able to comply, because usually they are local, deep-rooted systemic problems which are best resolved at that level. And it really would not have somebody from Delhi telling a practitioner in Mumbai what his problems are. So how can we use data not only for accountability, but more and more for data for improvement? So I'll just stop here. Do you want to add? Yeah.
Following
Yes.
that is like, when you thought about all your guidelines system, would you think in the same time, so you were indicated some indicators that can be used to monitor the guidelines, but did you already thought about a monitoring system, for instance, and like stick and carrots was evocated by Richard?
It's a very good question. So even with the guideline work, the guideline work is housed at the National Health System Resource Center, the NHSRC, which is the secretariat, which reports to the National Health Mission and the ministry. But they were given the development of the first 10 guidelines as a task. So it still has not found a home for itself, because guidelines need to be updated and more topics need to be taken in. So we do not have a continuous guideline, a single continuous guideline mechanism in the country. The second question you asked about monitoring of compliance to the guidelines, I think that still needs to be thought through. It's a very important question. What happens once we have these quality standards and we want compliance to it? Who looks at the data? How is it monitored? I don't know. We don't have an answer yet.
I agree with almost everything Dr. Mendiret spoke just now. To my mind, the single most important thing that is lacking at this point in time is a national policy on how to measure performance of healthcare delivery. So the National Center for Quality Assurance in USA has done a fantastic job in this regard. So they have come up with something called HEDIS, which stands for Healthcare Effectiveness Data and Information Set. So which talks about the performance measures. So be it 30-day mortality, infection rates in the hospital, be it survival, quality of life, evidence-based medicine, rational prescribing, rational request for investigations, and so on and so forth. So we may talk any number of times about the hub and spoke model and how it's going to be effective in kind of achieving access to healthcare, because access in a way is also linked to the quality of healthcare that is being delivered. So, but even for the hub and spoke model or any model to be successful, it is important that you have uniformity as far as the quality standards are concerned. So in this direction, I think a national policy is very, very important. The other second most important thing as far as India is concerned is the presence of complementary and alternative medicine. I mean, there is nothing wrong with complementary and alternative medicine. It's very important because they're trained in their respective fields of medicine. But you see many Ayurvedic professionals or homeopaths, who end up practicing allopathy in their day-to-day practice. So how is the government going to regulate that is another issue. So regulation becomes very important. So, and likewise, we have several other stakeholders, each of whom can contribute to improving the quality of healthcare delivered, including, like for example, insurance companies. So I don't think, I've never heard of anybody conducting a survey on patient satisfaction levels about the healthcare that they have delivered. So these are some of the things that should be instituted as soon as possible by various stakeholders, so that we know where we stand as far as quality of healthcare delivery performance of healthcare delivery is concerned, and so that we can take corrective measures.
Thank you, Mathurin.
I think
Would you give us the pharma perspective? Or we can deliver the right quantity to the right person in the right way?
Thanks, Karine. I think as I was listening to both Richard and Sharkan earlier, I reflect on the framework that Dr. Badve used earlier today, right, in terms of healthcare services, in terms of what is minimum, what is optimal, and what is optional. I think clearly I saw in those two presentations something that could help make those decisions, right? The health technology assessment definitely is something that could help, because our experience is at the level of Dr. Badve or Dr. Gupta, yeah, they get it, they understand it. But when you get further, right, going to the second tier, you start seeing people making the decision because they assume that this patient cannot afford it. And clearly that assumption does not take at all into account what's the outcome, what's the value, what's the impact. Therefore, technology like health technology assessment would be really helpful to really apply this type of framework in contexts like India. Again, reflecting to Srikanth's presentation, it was really beautiful to see that slide where you see all the source of financing of healthcare in India, from CGHS, ESI, type thing. Really, I'm really reflecting about quality, reflecting about output. There's a missed opportunity here, right? I think if you can imagine the negotiation pool that all these could have in order to really put out there and say, we will treat 5,000 women with cancer in India next year. The delivery model will change, right? Pull all this together, bring in the system. The outcome in terms of cost will be really, that bargaining power is not being leveraged. And we actually saw it this morning in the presentation of CMC Vedor and the presentation of Tata Memorial Hospital. If you see the pool of patients that those two centers are servicing, and you see the missed opportunity of pooling, the bargaining power in order to improve outcome and quality, I think there's an opportunity. That will be my comment, Karen.
Okay, thank you. I've got a last question, which is much before leaving the floor to the room, which is much more on if we are to discuss the efficacy of on-point delivery, how should we take into account the patient perspective? Because we didn't talk yet about that, and is that valuable in the Indian context, and would you consider doing so?
Well, I touched upon efficiency in my presentation, but I would like to highlight two things in the last 10 years. One is change in the mindset. 10 years ago, very few people in India were talking about quality of health services. They were mainly focusing on quantity. But now we hear a lot of discourse and dialogue on quality of health services, which is a good development. That's one part of it. Second dialogue is that when somebody should or is raising issue about quality of healthcare, I have noticed, or this is observation of many people, that people don't become immediately defensive, that, oh no, our quality is good. Now there is understanding that if somebody is raising issue of quality, we need not to be defensive, but let's look at it and then go ahead with the right intervention. And third and final point here is, in the last few months and years in India, there are some states which have given, made a policy initiative or put incentive on improving quality. For example, I'm sitting here in Maharashtra, and Maharashtra has a health insurance scheme. And any facility which is impaneled, if they meet certain quality standards, which could be X by Z, but then they are given additional package rate over and above what is being offered to non-quality, non-facility which do not meet those standards. So summary point say there is change in the mindset, there are much dialogue going on, and there are many actions going on in India.
Can I add? Your question brought to my mind a recent discussion I had day before yesterday. So I was at the All India Institute. We were facilitating a workshop on quality improvement and coaching clinicians to look at the data and improve outcomes. And as a part of the workshop, we had one exercise, what we call provocation to do creative thinking. And one of the concepts that was giving is patient treat doctors. So there is a reverse role, and you're the patient, and your patient is your doctor. So the one very interesting thing came out. There was a project being discussed on how do we decrease time from the time the patient comes to the ER. So they have a lot of patients who have leukemia and aplastic anemia who are coming for blood transfusions to the ER. And it takes approximately, when they checked the time it takes for till the time the patient comes and the blood is started, it takes about 6 to 8 hours. So he's just waiting in the ER for the blood to start. And the first thing the doctor said is that if I'm that patient, I don't want to wait so long. And if I'm that patient, I don't want to be there where I have no clue how much time it will take, where I would need to go, what needs to be done, and it gets the doctors thinking differently, because then we realize what the patient actually goes through when he visits our facilities.
I think there's been a lot of discussion about data and a lot of discussion about having that information in order to analyze it. I would like the health community or health sector to really look at the financial sector. The financial sector began with a lot of data which is not accurate, which is not done with the same quality it has been collected across. And then what happened was it was brought together and cross-analyzed with each other with statistical model and others. So they started emerging in their minds the patterns. And I think we need, in case of India, if we're really talking of a public health system, improving the quality of public health system, we need to have the data which can actually give us the pattern and which can help us identify and look at it, how the 36% inefficiency that we're talking in the system, because we're talking about a great amount of inefficiency. So my urging would be, and this is something I've heard over and over again, the people are talking, I don't want to name it, I met somebody in ICMR who's going to write the 10 field manuals to collect data to a certain quality. My problem with it is by the time the manual is written and by the time it's given and if it is at all followed, we'll still have the same data quality. And I think you mentioned it earlier, somebody that at the field level, when the data is there, they are have a lot of information, a lot of data. What they don't have is a motivation to what uses that data. And if we can somehow look at what uses that data at that point, you will see the quality of the data improving and the richness of the data improving. So I think today's day and age, that's a very, very important part to look at the socioeconomic aspect and the process aspect of the health system across the country and be able to continuously, by multiple iteration, look at it and analyze it. It is possible technologically. What is not possible is the fragmented, sectored, structured studies, as opposed to creating a data lake and examining what data that exists in the country.
Thank you. Do one of the panelists want to add on that? Or do we leave the question to the floor? Yeah, I think that there is a lot of questions here in front.
Go in order. So in the Indian scenario, with respect to quality, there are some observations that I wonder what the panel thinks about this. The first thing is that the average Indian doctor doesn't like to be regulated. And I've personally experienced sitting in committees where something as simple as standard treatment guidelines is primarily opposed by the medical profession. So on one hand, you have this problem. On the other hand, you want them as allies in this movement towards quality. So that's how are we going to deal with this? But the second question also is that there is also a spin on quality, which is that you have, and I don't mind using that term, NABH and all, who are essentially large corporate hospitals who use quality as a marketing tool. So there's a spin on that, and that's seen as a threat by smaller hospitals. So how does one deal with this? Any comments from the panelists?
Do you want me to take that? Do you want to answer, or you want me to take?
I can take the first question.
Okay.
So the answer to that question as to how you would implement these guidelines is, I mean, there's an interesting concept where, you kind of pay for performance. You pay for performance. This pay for performance, once again, is widely practiced in the US as part of the managed healthcare. And physicians get rewarded for being, adhering to rational prescribing practices, rational request for investigations, and so on and so forth. So if we can incorporate some of those aspects in, I mean, I'm not too sure, whether we can import it en masse, or we have to customize it to the Indian situation. But if we can do it in some way, I think even the regulators as well as the practicing physicians will be in a happy space.
Maybe I want to build on that and touch on what Sunil said earlier. With the availability of the data now, I think pay for performance becomes something that, in our industry, we are committed to more and more, right? I think, with the real world data today, access to medicine, mainly the innovative one, should be around pay for performance, right? See if it performs, if it delivers the disease-free survival in the real world situation, then the institution pay for it. If it doesn't, then there's a clawback. You have systems like that in France or in Canada. Yeah.
I would also add, I really, being a clinician, I can understand doctors don't want to be regulated. So I read recently somebody saying that you assess maybe a cricket or a football team by the number of wins and losses they've had, or a business company by their quarterly financial statements. How do you assess the quality between one doctor and the other? We live in a very opaque system. We do not, and that's how it's been built. And I do not know how many in the audience know about Dr. Ernest Codman. In the early 1900s, he brought this up at Harvard that we need to have doctors reporting their outcomes. He started his own end results hospital, and he was ostracized. And he was forced to leave Harvard and start his own hospital, and he virtually died in penury. And what he started, the end results committee with the Association of Surgeons, went on to be the Joint Commission later. But even a century later, it's still hard to get people to be open to having their outcomes being made transparent. Having said that, in places where benchmarking does happen, and if we look at the Bell's curve, for example, if we take an example of resurgery after a hernia operation, you will find that the outliers at one end will be that 1 in 10 surgeries will require reoperation, whereas at the upper end, you will have 1 in 500 patients requiring. And if we do not have data, and if we do not learn from those who are doing very well, how will we get better? So that's what I want to say.
I have a question to Richard. So, the healthcare indices of many Western countries are already reasonably good. Now, going forward, let's say in the next 10 or 15 or 20 years, how would you measure, by what yardsticks would you measure the efficiencies of healthcare delivery in Western societies from here onwards? So you have an infant mortality rate, you have the maternal mortality rate, you have the incidence and mortality from cancer. So from here onwards, what cost effectiveness, how would you?
I think your standard indicators are already there. I think at the end of the day, the indicators have to have internal and external validity, and you've got to be really sure what's going into them from a systems and national perspective is absolutely trustworthy. So unfortunately, we're seeing in many low emerging economies now, there's a lot of fabrication of health data for a variety of reasons happening. And that's very detrimental to the whole global health movement. So I think you really have to sort of focus on really the core indicators, and you've mentioned them already, the ones around the big Group 1, Group 2, Group 3, infectious disease, child and maternal mortality, the standard NCD indicators. Below that, I'm afraid, it comes down to the quality indicators around some of the cross-cutting domains like surgery, for example, and having national systems for collecting surgical quality data. Things that cut across from orthopedics, cancer, and you can pick out these big domains to look at those sorts of quality indicators. But we've not seen ever a healthcare system just simply have an emergent way of having quality. It is always required a mixture of punitive economic sanctions and or very punitive professional sanctions to get the quality levels to the level where it becomes a self-fulfilling prophecy. And unfortunately, it is just the reality of the way that systems and human beings work is that quality requires a lot of energy to put in to break that entropy. And that's it requires, I'm afraid, a bit of heartache and tears to be shed to get it to that level.
Thank you. Any other question?
So my question was over here at the back. Sorry. Right at the back. Yeah. So I heard it's very encouraging to hear about medical technology assessment in the Indian context. My question was, is it not putting the cart in front of the horse? Because what are we going to do with the result of the medical technology assessment? For example, the NICE in the UK, they appraise new technologies, and then subsequent to the result of that technology appraisal, whatever it is, yes, no, or conditional approval, there is impact on access. In the Indian context, what impact is that report going to have? I mean, so some thinking around that would be very helpful. Thank you.
Very good question, and there's a lot of thinking which is going on in the government on how to do it. So I don't have all the answers yet, but I do want to reassure that the health technology assessment is not going to have in isolation. There's going to be a process by which stakeholders, which includes the Ministry of Health and the State Departments of Health, would inform what are the prioritized topics which need to be assessed, and the recommendations made by the board will be given to the health minister. And I do not know whether it will go to state governments or that's what I'm saying, the process is still being formulated right now, will go because the aim is that it should feed into policy. I completely agree. It should inform probably the essential medicines list or what gets covered under the various programs. But what the actual mechanism is going to be, we'll probably come to know in the next 6 to 12 months.
Yeah. Yeah. My
I
question
want
is
to add one aspect on it and reflecting on the Australian model. I think to your point, the health economy assessment assumes that there is someone who is willing to pay. I think the challenge we have today is that, yeah, there is a level of payment, but that the financing of healthcare in India, if you want to run proper healthcare technology assessment, you have to adjust it with a different way of financing healthcare service in India.
Yeah.
That will be my comment.
One last question.
Question is to Mr. Chandrakant, WHO India. How much reliable is it for the health system in any country to rely on the politics of certain democracy or the nation? Because considering, like today our government is performing quite well, but looking at United Nations, Obamacare was launched, and right now the first thing that Mr. Donald Trump did was writing an executive order against the Obamacare. That has given an impact to their social health system. So how does it affects us?
I think. Thank you very much. This is a philosophical question, and all I can have a philosophical answer.
Got 10 seconds.
So, policymakers or politicians can bring the large-scale reforms. So we have to rely on them. We know in India, and this is Ashish Nandi, famous social scientist, who said that any reforms takes 11 to 35 years in average. And to bring change in the healthcare the way it needs to be changed, it requires political intervention. No technical, no bureaucratic intervention would be enough. That's it.
Very good.
So it's a good last word. Many thanks to the panelists, and for some of you who would like to continue the discussion, I'm sure they will be happy to discuss with you. Thank you.